Hey, my name is Mario, and this will be on internal tube feeding. Uh, for this video, my patient, I'm call Mr. Andy, has an NG tube, uh, and like I said, we're gonna just talk about the way about feeding in general. So first thing first, I always check the orders, see what the what the provider order or the dietitian for the feeding. So I go in. Hey, Mr. Andy, my name is Mario. I'm your nurse for tonight. You have some scheduled feeding. Depending on the type of feeding, sometimes it can be continuous or it can be bolus. But Mr. Andy, you have a bolus feeding. Let me look at your wristband. All right, can you tell me your name and date of birth? Okay. Do you have any allergies? No. Okay. So yeah, Mr. Andy, they recommended you have longevity 3 times a day. We're gonna give you Jevity, okay? Okay. So since you have an NG2 place already, and I'm gonna just make sure it's in the right place. So depending on not in the right place, I'm just make sure that he doesn't have too much feeding going on. So before I do that, let me go wash my hands. So I wash my hands, put on some gloves. So I got my gloves ready, patient on high Fowlers. And so from there, I'm going to grab his NG tube, grab my syringe, unclamp it. Like I said, he's going to get bolus feeding, so he doesn't have nothing connected to where he's getting continuous feeding. Put it in right there. My syringe, his NG tube, aspirate it. Now, if this is his first time getting feeding or anything in general, we're gonna see his gastric content and and then pour it out, get a pH strip, and see we're in the right place. But the second thing is, if he does have a NG tube or a PEG tube, and he's already getting feeding, so we're gonna aspirate that. And for this video, it's a bigger syringe, but it has to be less than 250 mils. So let's say I aspirate and it's at 220 or 200, just use your nursing judgment. But all right, it's below 250, not too bad. And then you flush it back in, and then probably like 30 mils of water. But let's say, for instance, we aspirate it, and then we pull it back and it's more than 250, it's 500. We're not going to give him no feeding. For sure, we're going to report this to a provider. All right, but let's say we pull back, it's 250 or 270. Let's say it's 270. All right, so it's 270, and that's way too high. We're going to push it back in, flush with 30 mils of water, and then we'll come back an hour and then try again. Let's say we try again, it's same thing, it's 280, or not 280, excuse me, still let's say it's 260. It's still too much, so we can't give him enough feeding, because Mr. Andy has a lot of fluid or feeding already in them, so we don't want to overload him on it. But let's just say it's at 200. All right, we're good to give his feeding. He's in high Fowlers, and he already knows about the feeding. He's getting bolus. It's not in a kangaroo pump. It's not going continuous. So, all right, Mr. Andy, we have your Jevity right here. Okay. I shaped it up, and I got my water ready to flush it. All right. So, all right, Mr. Andy. So I'm going to go ahead and take this out. Push this sucker in right here. All right, Mr. Andy. So first, I'm gonna flush it with 30 mils of water. Okay. So flush it with 30 mils of water. Let that go down. All right. So for him, Mr. Andy, he's getting 3 cans of Jevity. So I got my cans already opened up, and sometimes you can just put it all in a big container, kind of just pour it in the syringe. Or you can just do one by one, but it's up to you. So this is my big container with the 3 cans of Jevity. So I pour it in there slowly, and then it's going in, and when it's again kind of gets like halfway done or 3/4 of the way done, you add some more jelly. You keep on doing that process until you have given the patient the whole, the whole entire feeding, the whole, for him will be jelly, until he has the whole 3 cans in. So we did that. So now it's about to get done. We have 30 mils of water in here. So now, same thing, before it gets halfway done, I like to just go ahead and give him the 30 mils of water. We don't want to trap like kind of air, like we don't want to push too much air in the patient. So it's about to get it's like 3/4 of the way done with jelly. Go ahead and get the 30 mils of water, and go ahead and flush that. Okay, so it's flushing it. All right. So after that, we're done. He stays in a high foul position. We remove our gloves, wash our hands, and clamp this off before you remove your gloves, of course. But he's gonna stay in a high foul position because we don't want to lay him flat, because then all that feeding will come on back up, and that's the last thing you want to happen. So for Mr. Andy, it's like every 4 to 6 hours you want to come back to the patient. Do the whole thing, hand washing, don on gloves, check, and then with the syringe, you just got to pull back and just see how he's tolerating the feeding. Sometimes patients don't tolerate feeding well, especially if it's something new to them, like a new peg tube. Sometimes they won't tolerate so well. And same thing about the 250 mils. Especially it's been a long time and still haven't digested that. Yeah, that's a big issue. But after that, patients with, especially if they had NG2 for a long time, you always gotta just assess the nares. Or if they have a peg tube, assess around the peg tube. They'll typically have like a padding around the peg tube, and you kind of like just assess where the peg tube's at. Make sure it's not red, or especially there's no feeding come back. Because sometimes you'll see around where the peg tube's at, where it goes in the abdomen, you'll kind of see like feeding come around it, and that's something you definitely have to notify the doctor. Because sometimes it's just bad placement, or the feeding just coming out, so they just have to get a new peg tube. But yeah, always assess the site, assess the bandages, make sure it's taped off, and then if it's a peg tube or NG tube, make sure it's always clamped off, because that feeding will come out. But besides that, besides assessing the patient every 4 to 6 hours, having high fowlers, when it comes down to, for instance, continuous feeding. So for continuous feeding, you have 2 separate pumps, well, 2 separate bags, let me put it that way. You have one that has like the jelly, the feeding, and then you have another where it's the water, where they'll have the water, and then you have like a pump. For us, it's a kangaroo pump hanging on and then with that kangaroo pump, you'll adjust the rate, you'll adjust the flushing. You can have it set to every 30 mils and every 4 hours or every hour, depending on what the dietitian or doctor recommended. And then the same thing with the feeding. It'll be it can be like a 200 or 250, or start the patient off at 10 and go up to 50 or 60, whatever the feeding rate is. But you'll do that throughout the kangaroo pump. And especially people with peg tubes or NG tubes in general, you have to do eyes and nose, because this is the only source of nourishment, hydration they're getting. So you got to make sure that they're peeing. So because you don't want them they're not getting enough water, and their urine output is low. And then as far as feeding, sometimes they'll be you'll see very loose stools with patients with feedings, with peg tube feedings or NG tube feedings that have loose stools. We'll just try to, document the amount of times they have bowel movements, how many times they urinate. And then when it comes down to saying all that, like, the patient, you're already monitored. You came back 4 hours. You check how much you got back. The patient has no complaint. He's not nauseated. He's not there's he's no discomfort. Uh, you have to chart everything. So you chart the ins and outs. You chart the feeding, the flushes, the output, and of course the input. Uh, and it's the main thing with continuous feeding, like the longevity, not excuse me, like the kangaroo pump for us. So with that pump, with the feeding, it can only stay up there for 24 hours. So you can just get a marker and permanent marker and just or a label, and you just put in the time that you hung it up. So the time that I started the feeding or filled up that bag of feeding, you put whatever the date and the time. That's mainly it. And like I said, I always assess the nares or where the peg tubes at, where the NG tubes at. Always make sure you got the right feeding, the right flush. Make sure you're not complaining or uncomfortable or feeling full all the time. Always make sure that they're not retaining too much food or fluid. Cause like I said, you don't want to overload them, and because it does happen, and you just always have to check and look at this, look out for the best for the patient and the safety just in general. But yeah, that's the main thing when it comes down to feeding. Assess where the NG tube or peg tube's at. Make sure it's in the right placement. Make sure it's secured. Always educate them. Always look at the orders. Always make sure it's the right patient, the right feeding. Especially when it comes down to kangaroo pumps or pumps, feeding pumps. There might be the wrong feeding out there, or the doctor might have changed the feeding to a different type of feeding because maybe his blood sugar is too high and it's not the right feeding for the patient. But yes, that's the main thing when it comes down to it. Always chart everything you do. All right, that gets it.